here. So welcome, this is panel 1, answering the why. What does the research say about the importance of employment to recovery? This virtual symposium, Working Recovery, is sponsored by Massachusetts Access to Recovery and Project of Advocates for Human Potential, and funded by the Massachusetts Department of Public Health, Bureau of Substance Addiction Services. So with that, I am going to pass things over to Rebecca Starr, who is our moderator today, and she is going to kick us off.
Hi, can you hear me, Zach?
Yes, we can.
Okay, great. So I'm thrilled to be joined today by two distinguished research scientists who study each and every day what the challenges are that people with substance use disorders face and what variables can help them get past the addiction and maintain their recovery. We will first hear from Dr. David Eddy, who is a researcher at the Recovery Research Institute at the Massachusetts General Hospital in Boston. And he also serves as an assistant professor at the Harvard Medical School. His current research, supported by the National Institute on Alcohol and Alcoholism, is seeking to better understand the factors that heighten the risks for relapse for those individuals with addiction histories. He also studies addiction treatment and recovery processes, as well as drug and treatment policy, and serves as the finance chair of the American Psychological Association's Society of Addiction Psychology. Dr. Eddy is a licensed clinical psychologist. Also joining us today from across the pond in England is Dr. David Best, who serves as a professor at the Derby University in England. Dr. Best has a master's degree in criminology and a PhD in the psychology of addictions. He has authored 3 books on addiction recovery, and he's written more than 170 peer-reviewed publications and around 70 book chapters and technical reports. His current research focuses on recovery pathways, recovery capital, which he will describe, and how you can measure recovery capital and the implications for recovery. Dr. Best also, in his spare time, leads a multi-site collaboration on recovery pathways in Australia, and he's the principal investigator on a European project about recovery models and philosophies in the United Kingdom, Belgium, and the Netherlands. We thought that Drs. Eddy and Best would be the perfect people to start off our symposium by laying the foundation of why focusing on employment and work for people with substance use disorders should be such an urgent priority. The way that we're going to proceed is that the two of them will present one after the other, and then we will have an opportunity for the audience to ask them questions. The way you can ask them questions, as a reminder, is to type your questions into the Q&A box at the bottom of your screen. Dr. Eddy, welcome. And how about if you start off this conversation?
Thanks, Rebecca. It's wonderful to be here. It's so great to see such a fantastic turnout as well. Zach, if we could go to the next slide to get my talk started. Thanks so much. So I really want to lay the table today for the talks that are going to follow afterwards. So I'm going to be talking more about the problem that we're facing in terms of addiction and getting people back to work in recovery. So I'm going to be presenting some data from a recent nationally representative survey that we conducted at the Recovery Research Institute, which identified a number of key disparities that individuals in addiction recovery face in terms of getting back into the workforce. But before I jump into that study, I want to just quickly touch on this idea of recovery capital, which Rebecca mentioned briefly, and it's important. And Dr. Best is going to be talking about this much more afterwards. But just to help you frame why we think employment is so important in the addiction recovery process, we first need to think about this idea of recovery capital. So I define recovery capital as the sum total of resources available to an individual to help initiate and sustain addiction recovery. Because we know addiction recovery is not just about stopping substance use, right? It's about rebuilding a life. And for the folks who are able to rebuild a life, they're much more likely to stay in addiction remission, right? Because they have a life worth living. So recovery capital is a very broad umbrella. So, what am I thinking about when I think of recovery capital? I think housing stability, having access to healthcare, having social supports, like social recovery capital is really, really important. Having access perhaps to mutual help in the community, having access to leisure activities, being able to do fun things. And for me, employment, and if we could go to the next slide, please, Zach, employment is really the axle of which all the spokes of recovery capital fly for me. Because think about it, if you've got a job, you've got an income, right? So you're much more likely to have housing stability. And that's huge. That's huge. You're more likely to have healthcare, or at least have the money to pay for some healthcare out of pocket if you need to. You're going to have some income potentially to do some fun things, to engage in some fun activities, right? Socially, work can be really important for folks as well. It's a way of connecting with peers and building social networks of support. So employment is just so important to the accumulation recovery capital, and therefore to the addiction recovery process. Next slide, please, Zach. So we know this is important. There's a growing literature suggesting this. And I always looked at the clinical science and what that shows us. And we know that from a number of studies that people who are employed have higher rates of abstinence and lower rates of relapse during the early phases of addiction recovery while they're in treatment. We also know employment's associated with less criminal activity and improved ability to transition from residential to a community treatment. So it's not just important in terms of sustaining recovery. Employment's really important in the early stages of treatment as well. Next slide, please, Zach. So I probably don't have to tell you all that there are significant barriers to achieving employment for people in addiction recovery. And Secretary Wall spoke to this, Rebecca spoke to this. There are systemic barriers, legal barriers that can make it very, very hard for people to get back into the workforce. Discrimination around addiction, stigma, the failed war on drugs and legislation arising from that. For instance, if you have a drug conviction, under most circumstances, it's difficult, if not impossible, to get federal aid to go back to school in the United States, which is a massive barrier, right? Because we know education is a critical stepping stone to employment for many individuals. So there's all kinds of systemic barriers getting in the way. And if we can go to the next slide, please, Zach. And so the study I want to talk to you about today was a study we recently published in the Journal of Substance Abuse Treatment from a nationally representative survey we did. We really wanted to assess the state of the union, if you will, for folks in addiction recovery in the United States population. And if we can go to the next slide, please, Zach. So we wanted to know, in terms of employment outcomes, does our nationally representative sample of individuals who endorsed recovering from a substance use problem have similar or different employment statuses to the general US population? And we hypothesized that there would be significant disparities here. And you might also say, well, obviously there's going to be disparities. Like, why did you even do this study? You're just going to find what we all knew. Well, it's actually really important we did this study because we didn't have good data until this study showing this. And that's critical because even though we all know as people working in the field that these disparities exist, we need data, so that when we go to Capitol Hill, for instance, to lobby for change, we can actually go with data in our hand and say, this is real. This is not just speculation. There's data to support showing these disparities in the US population. So the first thing we wanted to do was just look at the big picture, comparisons between our sample of individuals who have overcome addiction and the rest of the US population. But then we wanted to drill down into our sample and see if there are any demographic factors that might influence people's employment status. So for instance, do men or women perhaps do better than one another in terms of employment? Are there racial disparities? Does education matter? Does that buffer people against disparities? So I'm going to speak to those findings as well. And then finally, we wanted to know if being employed, if you're in addiction recovery and you have a job, do you have better well-being? And again, I think everybody here would probably say, well, yeah, come on. I mean, obviously, but again, we didn't have the data, at least not the nationally representative data to support this. So this is an important study. Next slide, please, Zach. Okay, so what do we do? Next slide. Okay, so to start, we asked 44,000 US adults, did you used to have a problem with drugs or alcohol, but no longer do? And we used a fairly sophisticated surveying technique using the support of a survey company called GfK. And a lot of these epidemiological survey approaches you're going to see today are very similar to the survey approaches they use when they're doing national polls, for instance, around election time. Next slide, please. So we had about 25,000 individuals respond to our initial screening question, of which about 2,000 people endorsed having resolved a problem with alcohol or other drugs. Next slide. Okay, so we collected a bunch of demographic information about these folks, so we know a lot about them as individuals. We asked a lot of other questions not related to employment, because we wanted to answer a lot of questions about this population. I'm going to be focusing on the employment today, obviously. We also assessed individuals' well-being. So we asked about their quality of life, their self-esteem, and their happiness as well. Next slide. Okay, so we can skip through these analysis slides because I'm not going to get into these, but I wanted these slides to be here so folks, if they're looking back at these slides later on, have them as a reference. So next slide, please, Zach. And next. And next. And next. Okay, so let's get into the results. Next slide, please, Zach. So first up, big picture findings, about 9% of the US population endorse having resolved an alcohol or other drug problem, which is a lot of people, right? And when you think about this, right, 9% of the US, almost 10% of the US population endorse resolving an alcohol or other drug problem, and probably about 5, 10, maybe even a little more percent of the US population at any given time has an active substance use disorder. You start to get a sense for the scope and the scale of this problem. And it's why it is so important that we're thinking about these issues like employment, because we're not talking about a trivial sliver of the US population here. We're talking tens and tens and tens of millions of people, big chunk of the US population. So we asked people what their primary substance was that they had a problem with, and you might not be surprised to see that about 50% endorsed alcohol. That's pretty typical. Way more people have a problem with alcohol than all the other drugs combined. But notable as well, about 11% of the population endorsed that cannabis is primary, 10% cocaine, 7% methamphetamine, and 5% opioids. Now, opioids account for a lot of the drug-related deaths in the United States, but really alcohol, if we're looking at big picture, causes a lot more problems. Next slide, please, Zach. Okay, so what do we find in terms of employment disparities? So I'm going to walk you through that. We had 7 categories of employment in our survey. We weren't able to compare all of these categories to the US population because we were using US Bureau of Labor Statistics data. And so they didn't have a working self-employed category that we could compare to. They didn't have a not working other category that we had in our survey in the Bureau of Labor Statistics data. But we were able to make comparisons on a bunch of other measures. So first, let's look at the top line there, working as a paid employee. Significant disparities here. So our National Recovery Study sample, these folks who endorsed being in addiction recovery, were significantly less likely than the general United States population to be gainfully employed. And this is a big effect too. And you can see the raw difference here is almost 10%. And when you start to think at the level of the US population of 320 million people, these are massive disparities. In terms of not working on a temporary layoff from a job on the third line there, again, we see significantly more individuals in our sample compared to the US population endorsing this, 3 times as many, in fact. Folks in our sample were also much more likely to be not working and looking for work. And interestingly, they were less likely the folks in our sample to be retired. They were more likely to be disabled as well. So what do we think is going on here? Well, this is survey data. It's a snapshot in time. We didn't follow people longitudinally. So we have to be careful about the kinds of inferences we draw from this data. But clearly there are disparities here, right? And we think that's probably a function of the barriers to employment that exist in broader society. Now, you might say, well, some of the folks in your sample were probably in early recovery, probably that, they were still in treatment and it was too soon for them to be getting back to work. Well, that's absolutely true. And I'm going to show a slide later on that shows some data about that. But these differences are massive. So there's clearly some systemic barriers that are getting in the way of people getting back to work. Now, you might wonder, as we did, like, why would folks in our sample, the addiction recovery sample, be less likely to be retired after controlling for age? Well, what we think is happening is that folks are probably staying in the workforce longer to offset financial losses as a result of active addiction. And regarding disability, well, perhaps that's not too surprising. Substance use disorders give rise to all kinds of medical problems that people often struggle with well beyond overcoming their addiction recovery and into long-term sustained remission as well. So it's perhaps not surprising, but what is a little bit surprising is just the magnitude of these numbers, how many more people in our sample are not working because of disability compared to the broader United States population. So next slide, please, Zach. Okay, so what do we find in terms of the demographics, in terms of within our sample, what are the individual factors that might influence whether somebody's employed or not? Next slide. So first up, we looked at sex. We wanted to see if men and women were fundamentally different unemployment measures. They weren't in our sample. So there were no sex differences. Next slide. There were, however, race differences, and this is really important. So we found the individuals in our sample identifying as Black non-Hispanic were 50% less likely to be employed than white non-Hispanics. So there's a massive disparity that's being experienced by a subpopulation of individual within a population of individuals who are already experiencing disparities. So there's a lot of work needs to be done here, not just in terms of addressing employment disparities for the broader recovery population, but within this, racial subgroups are particularly vulnerable, particularly individuals identifying as Black non-Hispanic. Next slide, please. We also looked at arrest history, and we hypothesized, we thought that the folks with greater number of arrests would be more likely to have problems with employment because a lot of employers do background checks and disqualify candidates based on criminal records. And that's in fact what we found. So compared to those individuals with no previous arrests, those with 2 or more arrests were 43% less likely to be employed versus unemployed and needing work. And you're going to hear a lot of solution in the talks following mine today. Again, I'm highlighting the problem, but this is really a key issue. We need to be creating access to employment for individuals with criminal records. Next slide, please. Okay, so I mentioned earlier time since resolving a substance use problem and how that might influence with people getting back to work. You would expect there be a little bit of a lag period while people are still in active treatment before they get back into the workforce. And what we thought before doing the study was that, probably the first year of recovery, you're going to see a lot of unemployment among those folks because they're still in treatment, they're still getting their lives together, they're still trying to segue back to work. But what we were surprised to find was how long it takes people to get back to work. So we found here in this graph, we've got folks categorized as either in the having less than 1 year since problem resolution, 1 to 5 years, or greater than 5 years on the right there. And what you see from this graph is that it's taking, on average, folks about 5 or more years to be more likely to be employed versus unemployed and needing work. So this is concerning. It means we're probably not doing a very good job at helping people get back to work in a timely fashion, which really all the more speaks to the necessity of today's symposium and the work that's happening in this area. Next slide, please. Okay. it's not all doom and gloom. There's some good news here. It looks like education, as we anticipated, is a potent buffer against unemployment and employment disparities for this population. We found that folks with greater education were significantly more likely to be employed. Now, on one hand, this is cause for concern because a lot of people come into addiction recovery with disruptions in their education or even with very minimal educations. But the important thing here is education is malleable. We can offer people education. We can provide them with education resources. And that means we can actively take steps by connecting people with education to buffer the employment disparities they're likely to experience. And I didn't mention this before, but I'm in addiction recovery. And for me, education was just so critical for helping me break the vicious cycle of addiction and helping me sustain my addiction recovery. And it's really what allowed me to be in the career I'm in today, because I was in a completely different world before I found addiction recovery. And education was really my not just my key out of addiction, I believe, but the key to the life I have now and the sustained recovery I have today. So next slide, please. Okay, so I mentioned we also wanted to look at associations between well-being and employment status. So we predicted that folks who have jobs are going to have better well-being, as everybody here might predict. And that's in fact exactly what we found. The folks who were employed were statistically significantly more likely to have greater quality of life. They were more likely to endorse greater self-esteem, and they were also much more likely to endorse greater happiness. Next slide. Okay, so all that said, there are some limitations to this research. As I mentioned before, this is a cross-sectional survey, which means we just took a snapshot in time. We didn't follow folks longitudinally. So that limits the kinds of inferences we could make in our when we discuss this kinds of work. But nevertheless, this is a really important foray into this one. It gives us critical data showing these disparities in a very concrete, methodologically reliable way. And of course, as with all surveys, we're relying on participants' retrospective recalls, which could have bias, or there could be memory issues that impair the accuracy of these findings. At the same time, there's a lot of strengths associated with asking people about where they're at. So participants also self-identified in this survey as having an alcohol or other drug problem and having resolved that. They didn't necessarily have a substance use disorder diagnosis, but at the same time, I think that's a strength as well, because a lot of our research focuses on people who have been clinically diagnosed. We really tried to capture the entire population of people who endorse having overcome an addiction in the entire US population. Next slide. So to conclude, compared to the US population, individuals who have resolved an alcohol or other drug problem, they're less likely to be employed or retired and more likely to be unemployed and disabled. And importantly, unemployment rates are larger among already marginalized populations, such as people identifying as Black and those with multiple history of a multiple arrests. And also high levels of education and longer time since problem resolution clearly buffer employment vulnerability. Next slide. Just want to quickly thank the funders of this research, the Recovery Research Institute at Mass General Hospital, and also NIAAA and NIDA, the National Institute of Alcohol Abuse and Alcoholism, and the National Institute of Drug Abuse, for whom without their support, we could not do this research. So thanks very much. I look forward to taking some questions after Dr. Best's talk.
Hi, good morning and welcome from late afternoon in the UK. Can I just check with Rebecca, Zach, that you can hear me okay?
Yes, we can.
Yeah, perfect. Well, thank you for a great talk, David. That was fabulous. And I noticed there was a comment about audio and problems with the quality of audio. If you think there's problems with the quality of the audio now, it's probably just my accent. So don't worry about it at all. It's just the garbled form of English that I speak. So I'm going to move forward. Time is short. I'm going to take a different approach from David because I'm going to cover quite a lot of territory in a relatively short space of time. I'm not going to talk about one study. I'm going to take you through a number of studies. Next slide, please, Zach. Let's start with some basic stuff, some key American data about what we think is roughly the characteristics of recovery. So on the left-hand side, what are some of the things we know? Well, roughly 3 in 5 people who have a lifetime substance use disorder will eventually achieve stable recovery. And David in his talk talked about people who get to 5 years or more. Well, we refer to that as stable recovery. Why? Because the relapse rate gradually reduces from well over 50% in the first year of remission to 14% in year 5. And this is and pretty much plateaus at that point. So the concept of the recovery journey is to move away from acute clinical intervention to community-oriented recovery focused, where things like jobs, friends, houses become much, much more important than symptoms, than symptom management. There's a flip from managing deficits to building strengths and resources. And as David has already said, meaningful activities, including but not restricted to employment, are absolutely central to this. People do go through a number of episodes of treatment before they get there. And typically what will happen towards the end of an addiction career is that people will stop because something bad happens in their lives. They get arrested, they lose their job, they get thrown out of home, on top of being cumulatively fed up with addiction and the addiction lifestyle. But why they stay stopped will typically be about other people, about moving away from people involved in using to moving towards people who actively support recovery. So those are things we know about recovery. The right-hand side originally comes from the mental health recovery movement, but it switches to, and what can we do to support people move to that recovery? And Leamy and colleagues reviewed the literature and came up with a wonderful acronym summarizing the evidence from the studies they reviewed, which is CHIME. And it's pretty much, for me, almost in the right order, nearly, but not quite. So I'll slightly cheat with the order of CHIME. What does CHIME mean? What can we do as services, community groups to support recovery? We can support connection to positive pro-social individuals and groups. Those connections through processes of social learning and social control generate hope and belief that change is possible. That hope is like the fuel in an engine that creates the energy to engage in meaningful activity. And engaging in meaningful activity allows people to develop a positive sense of identity and a sense of empowerment. Now, sadly, it doesn't read so well if you say CHME. So we'll stick with CHIME, but it's actually connectedness, hope, meaning, identity, empowerment, at least as far as I can see. Next slide, please, Zach. So I'm next going to take you through 3 studies that I led well, 2 in the UK and 1 in the US. The first of them was about people in recovery from alcohol and heroin in Glasgow and Birmingham. So 1 city in Scotland, 1 city in England. And they are all connected by something that I'll refer to as Goya. And Goya is after the Spanish painter, Francisco Goya. And I'll explain the acronym at the end of the 3 studies. So what did we find about well-being and quality of life in recovery? Well, there were 2 big predictors. The first was who you spent your time with. The more you spent time with other people in recovery, the better you did. But not only that, the more you did, the better you did. So how you used that time, and it always didn't matter what kind of pro-social activity, childcare, community group involvement, volunteering, education, training or employment, the more of that you did, the better you did. So we published this and we got some feedback, and people said, how do you know that's not the wrong way around causally? How do you know it's not the case that people who are doing better engage in more activities? Next slide, please, Zach. So we then conducted a follow-up study where we looked at changes in meaningful activity in 3 drug action team areas in England, where longitudinal data was available about people involved in either employment or involved in education or training. So we were able to monitor groups of people who maintained employment or education, who initiated employment or education, or who stopped education or employment, and those who never did any. There were clear directional relationships. Where people started meaningful activity, their physical well-being, their psychological well-being, and their quality of life went up. Where they stopped those things, they went down. Where people continuously had involvement in employment, education, or training, their quality of life, physical well-being, and psychological well-being was significantly higher than people who didn't do any of that stuff at any time. Now, there are reasons and factors behind this. It's not like we're necessarily comparing like with like, but nonetheless, there's a clear relationship. Both of those studies in the UK, both of them 10 years or so ago. Next slide, please, Zach. This next slide is remarkably meaningless to everybody. This is a structured equation model, but what it shows is exactly the same as we showed in Glasgow and Birmingham 10 years ago. And if you start at the bottom left, so this is recovery residences in Florida. If you go into a recovery residence and you stay in it, there's a reduction in barriers to your recovery and a reduction in unmet needs. But if you read from the bottom left up the way, and you also engage in meaningful pro-social activities, what you get is a different effect. You get a strengths-based pathway to well-being. What do we mean by Goya? Goya is a highly sophisticated scientific term that stands for get off your arse. The more you do, the better you do. And through these three studies, 4,000 miles apart, 10 years apart, what we have shown, I think, quite clearly is CHIME in action. Engaging people with positive pro-social groups or individuals creates the conditions, creates the role modeling and social learning that allows people to engage in the meaningful activities that then provides them with that sense of empowerment, that positive sense of revitalized and reborn identity. Next slide, please. And that links to the absolute heart of this talk for me, which is about recovery capital. David gave a definition of recovery capital a little bit earlier, and I'm just going to refresh that. So recovery capital has been considered to be the sum total of resources available and accessible to support the ongoing recovery journey. In work I did with a researcher from New York called Alexandra Lodi, we split it into three slices of pie, and you'll see my own obsessions by the various food references in my presentation. So anyway, we'll start with a pie. And the aim of the pie to start with is to fill the top left-hand slice, which is personal recovery capital, which covers things like self-esteem, self-efficacy, communication skills, resilience skills, and coping skills. And if you go for an old-fashioned kind of talking therapy model, it's almost like you start by building those things up and then you fan out to the social and community. But if you take a recovery model, you take a different perspective. These things are the things we think take the 5 years to grow and nurture and develop. And how do you do it? You do it through the other two processes, by supporting changes in social networks and by active engagement in community groups and processes. In other words, how you initiate CHIME is through connection, social recovery, and meaningful activity, which is through access to education, training, employment, housing, and so on. And for me, this is absolutely critical. But the other thing that recovery capital gave us was not only a flip from a reducing deficits model to a strengths-based model, it also gave us a much more cogent basis for a science of recovery. Here is something we can now start to count and to measure and to identify what the mechanisms are that support the building of recovery capital. Next slide, please. And I was delighted to see in the Executive Office of the President's statement earlier this year that recovery capital is explicitly mentioned, as you will see on line 2 of this extract from the ONDCP statement earlier this year, that recovery capital is now recognised as a sensible and meaningful metric. And I think it's the kind of task of people like myself and David to try and address that by working out what exactly we mean by recovery capital, and also how we can manage the dynamics in seeing this grow and develop. Next slide, please. So for me, the notion, can you just keep flowing this one on? Yeah, there's 3 bits to this. In our model so far, the idea is that you can measure recovery capital, and we've come up with a scale called the RECCAP, but it's not a science research measure alone. It informs recovery care planning, and recovery care planning necessitates and requires active and assertive navigational support or linkage to community groups and activities that promotes and actively encourages citizenship. And there's something fabulous about this. And if we go on to the next slide, please. I did mention my food obsession earlier, as you could probably see from my appearance. And we'll move now from pies to ice cream cones. So there is an important thing you need to know that differentiates social and recovery capital from financial capital. Sadly, as all of us know all too well, if you have some financial capital and you spend it, there is less of it afterwards than there was at the start. A sad reality all of us realize, apart from my son who's 13, who hasn't worked that bit out yet, who just seems to think the money constantly renews. Anyway, apart from him, people know that. Social capital, on the other hand, is different. Social capital operates on the principle of the more you use it, the more you deploy it, the more there is out there. And so there is something fascinating about how recovery works as a socially focused recovery capital-based model. And in my world of recovery capital, the little man at the bottom of the ice cream cone is the ultimate beneficiary. His growth of personal capital built upon by social capital, built upon by community capital, also has a benefit, which is the giving back to communities. But not only does that involve people paying their taxes, but we know that people in long-term recovery are much, much more likely to be active citizens, to actively contribute to well-being of their communities. And life and recovery surveys in Australia, where David is from, in the United States by Faces and Voices of Recovery, and in the UK have all clearly and consistently shown that people in long-term recovery, the majority of them, 75% in the UK case, are in long-term employment, but they are also twice as likely to volunteer in their own communities as people who were never addicted in the first place. And this is the sprinkles on the top of the ice cream cone, that it moves from being a pathologized body model to something that's a fundamentally social process of contagion and growth, that the more people who engage in who achieve long-term recovery, the better for their families, the better for their neighborhoods, and the better for their communities that they live in. Next slide, please. I now want to give you a very specific example, which I just think is incredible. And we're now on to model 2 of this just now, about something called Jobs, Friends and Houses. So next slide, please, Zach. Jobs, Friends and Houses was set up in the northwest of England by Lancashire Police Force, one of the police forces across England, with a very cunning plan of how do we get offenders coming out of 2 prisons, HMP Preston and HMP Kirkham. How do we sustain the recovery? We train them to be builders and we get them to physically build the recovery community. So what did they do? While people were in the pre-release period in England, what are called open prisons or category D prisons, they started apprenticeships in things like plumbing, joinery, electrician, apprenticeships in the building trade. And they either built or renovated new housing for recovery housing. It was a social enterprise, so 50% of the houses were sold to sustain the business, but 50% were retained and rented out to the builders as recovery housing. So effectively, this was in a very literal sense, people building their own recovery housing. We did the evaluation of the first 50 people. Oh, and incidentally, I should probably also mention the fact that there were, now let me try and get the data right. The average offending rate in the period prior to going into Jobs, Friends and Houses for this group was 3.27 per year. recorded and arrested offences, and it dropped to 0.15 in the first year during Jobs, Friends and Houses. This represented a 94.1% reduction in recorded crime among a group of people who had a total of, I think, 128 prior imprisonments. And there were only 7 positive drug tests in the first year. Next slide, please, Zach. Leading to not only these reduction, but you get a flip over with things like benefit claims. People stop claiming benefits and start paying taxes. And so there's this huge, so among 50 people, there was a benefit to the public person in the UK of around £800,000, which is just over $1 million US. This is a massive thing. Now, we had some kind of Hawthorne effects. This was a trial run. We're now replicating and repeating this in an equally deprived area of England called Middlesbrough in the northeast, where the aim is very much about, can you get that model, that combination of housing and jobs as a mechanism for change? But you will see that the name isn't Jobs and Houses, it's Jobs, Friends and Houses. Next slide, please. And something that we published in a journal called Social Science and Medicine was a paper where we looked at one of the things about who succeeded. So Jobs, Friends and Houses had an open Facebook page, and we subjected the open Facebook page to 2 lots of data scraping analysis. What a truly revolting name for a research term, but nonetheless, data scraping is downloading social media posts. And what you see in each of those 8 diagrams is a social network analysis. So the 8 diagrams are months 1 to 8 of the Facebook page being available on Jobs, Friends and Houses. And you will see the increased concentration of posts. Incidentally, the 3 groups of people depicted are clients of the project in red, staff members in blue, and the wider public, people who expressed their support and interest in green. And you will see the tight clustering here. Why am I telling you about this? Who cares? Next slide, please. What's important about this was, we found that the people who were retained in Jobs, Friends and Houses were the people whose comments were liked, endorsed by other people. In other words, they were a valued member of the group. The closer to the center of the social networks they were, the more retained they were. And fascinatingly, the less they used I language and the more they used we language, the better retained they were. In other words, friendship here, social capital here meant not only that you were in the middle of the network, but other people valued you. There was a giving back component and a sense of collective identity and efficacy. Why is this interesting? Because at the start, Jobs, Friends and Houses really was an employment and housing project. But the importance of the social component of it was absolutely central. And because this is in effect an enactment of the Chime principles, positive social connection combined with hope allows people, and lots of the people in Jobs, Friends and Houses had never worked or never held down a job for a long time, allows them to engage in meaningful activities, and it creates a new sense of identity. Lots of people in Jobs, Friends and Houses went to meetings, but one of the things that was fascinating was JFH as a company was very high visibility. It had logos on the buildings, it had logos on the t-shirts and on the jackets and on the builders' hats. They wanted this to be something to challenge stigma and challenge exclusion as an active part of the process. And we're doing exactly the same in Middlesbrough, where we've added a dimension, which is to get some of them in the weekends to take out bicycles into the more deprived housing estates and say to people, we'll give you a free coffee from the back of our bike if you'll talk to us about recovery for 10 minutes. This is a model of connection and hope. And I hope that this has been interesting and useful. I realize this has been a bit more varied than the direct focus on an individual study, but I wanted to give you this sense of how we start to think meaningful activities, jobs, volunteering, education, allow people to build those internal changes that allows them to recover. But that requires us as groups and societies to create pathways to community resources to allow those opportunities to develop for people. Thank you very much.
Thank you so much to both Doctors David Eddy and Dr. David Best. We do have a couple of questions. Unfortunately, we only have 5 minutes left to answer them. So I'm going to ask you to answer as quickly as you possibly can. Dr. Eddy, first for you. You mentioned a journal article in your presentation. Is there any way for the audience to get access to that journal article?
I can send it to you, Rebecca, and you could have your team circulate that. How's that sound?
Okay, great. All right. The other question that came in for you that several people asked similar questions was, you talked about your research being in the United States about the hugeness of this problem of drug addiction. Do you have any idea how the US compares to other countries in that arena?
That's a great question. And actually, David Best could probably talk to this better than myself, given he straddles, he has academic appointments in the UK and in Australia and does so much work in the US. But I see I can't imagine that these findings would look any different in any other Western country. And we see the same disparities, the same problems. Is that a fair assessment, David?
Yeah, absolutely. I think, the league tables are incredibly misleading is the other thing. Europe constantly produces league tables of drug users. They are very misleading because data is collected in slightly different ways in different countries. But I think the American situation, both in terms of trajectory and in terms of prevalence, is towards the higher end, but not atypical.
Interesting. Okay. Dr. Best, here's a question for you. First of all, people wanted to know what the acronym ARC was in your chart.
Assessment of recovery capital. It's one of the measures of recovery capital.
Okay. And you talked a lot about connections with people, positive people. Did any of your research include a specific study of connections to self-help groups like AA or NA?
Oh, absolutely. And I'm going to flick this one back to Dr. Eddy, because David and his colleagues at RRI have done an awful lot of work that's about the benefits of engagement with mutual aid groups. And David and John Kelly have done some incredible work that shows the effectiveness of engagement with 12-step groups compared to specialist treatment, where they fare every bit as well. I mean, one of the things I think that we are increasingly aware of is that it's not just mutual aid groups. There's a fabulous benefit to 12-step mutual aid groups, but also to other mutual aid groups and also to recovery community organizations. So there are clear evidence benefits. And in our European study, incidentally, one thing I would just very quickly like to say is we have shown that people who go to mutual aid groups and treatment, specialist treatment, do better than people who go to either on their own. And that seems to be a massive thing and overcomes lots of drug workers' skepticisms about spiritual or mutual aid groups. David, do you want to add anything?
No, you said it so well. You're spot on. We have ample evidence now. AA has been the most studied. We have plenty of reason to think that other mutual help programs are also just as helpful. But AA appears to produce results just as good as first line, top grade, top shelf cognitive behavioral therapy delivered through a clinic by a doctoral level clinician. And that's, I think, because mutual help groups can do a lot of things we can't do in the clinic in terms of connecting people to a recovery community. And also these programs are ubiquitous. And the great thing is they're not mutually exclusive. Like people absolutely, there's a synergistic benefit from engaging in formal treatment in combination with mutual help programs and or recovery community centers.
So unfortunately, our time is up. I know we could go on having a conversation for hours because this is such fascinating information. I want to thank you both so much for being here and sharing your research with us and your thinking and your wisdom. And maybe we'll invite you back so that we can spend a little bit more time with you and ask you even more questions.